Hey everybody, before we dig in today, I want to thank Tim Shell2. This is a person who left a 5-star review in Apple Podcasts back in January. This is actually the first review that anybody left for the show. They said, "It's fascinating. I can't wait for future episodes. I'm highly intrigued." They left that review after the first episode with Kat Bohannon, and I hope that Tim Shell2 is still highly intrigued. And I also hope that more people will do what Tim Shell did, leave a rating and review in Apple Podcasts or rate the show in Spotify. I love reading your thoughts about the show. And I would also really appreciate it if you recommend the show to a friend. All right, let's get to it.
I call it the emperor's new clothes phenomenon, where everyone's like, I don't want to make it sound like I'm weird because I had this crazy thing happen. But then once everyone realizes that the other people are having it too, they're like, are you serious? It's not just me, it's everyone. Like, we're breaking down the silence and the taboo around talking about bleeding, periods, pain, all of that stuff, because that does kind of keep people feeling like they're alone, like they're isolated.
Love, don't lose love.
Meet Dr. Karen Tang. She's a brilliant gynecologist, and she says our ideas about women's health are still haunted by centuries of misinformation. She's working hard to dispel myths and make everyone more comfortable learning about reproductive health. She says up to 90% of women, and also trans men, experience menstrual abnormalities or pelvic issues at some point in their lives. 90%. Too many people are suffering in silence, and that's why she wrote a comprehensive guide called It's Not Hysteria: Everything You Need to Know About Your Reproductive Health But Were Never Told. Dr. Karen Tang joins us to talk about it right now. If you've ever met with a gynecologist, this episode's for you. And if you haven't, this episode is also very much for you. I'm journalist Blair Hodges, and this is Relationscapes. Dr. Karen Tang joins us. Dr. Tang, welcome to Relationscapes.
Thank you so much for having me.
Now, you're not a historian, but you did do some historical research for your new book, It's Not Hysteria, because looking at the past can help people understand problems that we're facing today. Here's a quote from you. You say, "Women's bodies and medical concerns have been misunderstood, mismanaged, and outright dismissed from the beginning of recorded history." And you trace it back through this word hysteria, which is in your title. So take us back to ancient Greece and where this word came from.
I love this. And just like you said, the reason for it is because I do think that, the way that we treat women's health and women's bodies, it didn't sort of come out of nowhere. It's been sort of ingrained in our cultures and the way that we perceive all of this for thousands of years. And so it's something that I thought was very interesting to look back and kind of dig into. Where did these, myths and misinformation come from?
Do they do this in medical school, by the way?
No,
Like, is
not
this
at
something
all.
that they're
No.
okay? Right, okay.
I wish they did. I thought it was really fascinating.
Maybe like one class on it or something.
Just
at
like
least,
a lecture. So, yeah. But yeah, back in ancient Greek, ancient Egyptian times, there was this perception of something called the wandering womb, which I love this idea. They literally believed that the uterus just wandered around. It like moved around the body. It was seeking things or running away from things. So, for instance, the things that it was seeking were like sex and pregnancy. And so the treatments for a lot of medical ailments for women were things like, you should get married and have sex. You should try and get pregnant. Now, I mean, that sounds ridiculous, but I bet many of your listeners have probably been told that the treatment for things like endometriosis is go get pregnant. And it's not uncommon for people to be told this. And there's a teeny bit of like fact that kind of underlies it. For instance, like in endometriosis, people do sometimes feel better temporarily when they're pregnant because of hormone changes. But it's obviously not like a long-term treatment plan. Like you can't just stay pregnant for like 20, 30 years. So again, it sounds like ridiculous on the surface, but there are still some of these little elements that are still present today. And then, I trace it back, through history into the 1800s where you have Freud and, where they thought the hysteria was this manifestation of anxiety and repressed mental issues that manifested as physical problems. So this is where you get some of this idea that a woman, it's usually a woman who is complaining of a lot of things, seems highly anxious about their health, that it must be, mental rather than physical. And a lot of times we're discovering, obviously, that women who complain about a lot of medical issues often do have a medical problem. So endometriosis, for instance, can cause many, many, many symptoms across so many different organ systems. It can affect your bowels, your bladder, your muscles, your nerves. It can cause migraines. So when you see that list of complaints, sometimes people will be like, oh my gosh, that woman, must be like just super anxious or a hypochondriac, when in reality,
or her womb is wandering to all those places.
Her womb is just crazy. I know. So you get
it's going everywhere.
It's going everywhere. So you get kind of this combination of, your reproductive organs are going haywire. You're super anxious. It's making you a hypochondriac. And obviously some of those are still present in the way that people are seen today. So even though like the stories, they sound very shocking and very like, oh, wow, that's crazy. And obviously I'm a doctor. In the field of medicine, we like to pride ourselves on everything being very evidence-based, but we're human beings. And a lot of times some of these myths and misinformation get kind of absorbed, whether we realize it or not. You get these ingrained biases, and that impacts how you see a patient, how you process the things that they're saying, the lens with which you're viewing, someone's concerns about their health.
Yeah. And we should mention, too, that word hystera, I think, is the ancient Greek word for uterus,
yes,
where
exactly.
hysteria comes from. Like, hysteria is sort of a problem with your uterus.
Yeah, it's literally referring to your uterus. Yeah.
Yeah. And it gets tied into these ideas about emotional health, right? So hysterical became this word in the late 1800s and through the early 1900s. And so you talk about some of the treatments that women underwent, some of them pretty horrifying or pretty intense, where they would want to treat insanity or mental illness or epilepsy with some pretty intense surgical procedures, like even
removing your clitoris. Yeah, exactly.
Yeah.
So, I mean, you laugh, but it was horrible. So in the 1800s, again, I looking back at this, like the 1800s was like the Wild West in medicine, especially with women's health. And they literally tried all these different surgical treatments, like remove your ovaries, remove your clitoris, remove your uterus. Like, obviously, those didn't last very long because there were a lot of complications, and clearly they probably didn't fix the original problem. But there were times, I think in the book I mentioned, there were like thousands of oophorectomies, removal of the ovaries, used to treat hysteria. And again, like there were all these thoughts about, like there was things called like the rest cure, where you literally just like had to be sedentary. You couldn't like overstress yourself because you were too hysterical. You had to just be
you'll get the vapors.
Silent. Right, exactly. So those of you who have read like The Yellow Wallpaper, the famous short story about a woman who is almost like infantilized. Like she's literally like trapped in like a child's nursery because she's too hysterical. Like she needs to just sit there quietly, and it actually drives her mad.
Yeah.
And so like at the end of the story, like she's like broken free, and but she's actually kind of like descended into madness a little bit. But again, I actually in the book make the analogy of sometimes the treatment is worse than the problem you're trying to treat. So, for instance, a lot of times for gynecologic conditions, we use birth control a lot, which, it can work very well for certain things. It can decrease period pain and lighten bleeding, helps with PMDD, a premenstrual dysphoric disorder. But some people do have side effects with it. They can have like mood problems. Like sometimes the side effects are worse than the problem you're treating. So
severe migraines, I've heard, is one.
Yeah, it can cause migraines. And so in the end, like I said, it's not as extreme as like trapping someone in a room, but you can have someone who's like, I actually was feeling better before this treatment started. The same thing. And with the birth control, I always say, if there was, say, a situation where everything that a man went through was treated with the same type of medication, like, does that sound like that would be okay to the general public? Probably not. But for women, we just use birth control for so many things. And the problem with that is that there's just not enough research into alternative treatments where we're like, well, we have this, we know it works in some people. So we're just going to keep on using that for literally everything. And it does work for a lot of things. But the fact that we just don't have like more of an armamentarium for all of these vastly different conditions is, again, I think there's some misogyny in that. And it goes back to the fact that we just don't have enough research and funding.
You also introduce us to some of the ways that racism got embedded in the early field of gynecology.
Yes.
You're talking about important medical advances. However, some of the really problematic ethical things that were happening. Maybe spend a second introducing people to that if they haven't heard about this.
Yeah, so there's a lot that even as a gynecologist, like I never learned about in my training. So it was only in recent years that I think people had started to learn about the history of J. Marion Sims, who we call the father of gynecology. So literally this man, he was like the president of various medical associations. He had statues all over the country. He was one of the most famous doctors probably in American history. And he experimented on enslaved women. Like he practiced surgeries, like specifically surgeries for fistulas, like obstetric fistulas, which are injuries that recur in childbirth, on enslaved women. And it is really quite a horrifying history. There were only three that we have names of, like Anarcha, Betsy, and Lucy. So those are the women who have been talked about in recent years. Books have been written about them. But there were many other women who just had no names recorded in history. He became very famous. We even have like instruments named after him. He invented the modern speculum, which is the instrument that we use for pap smears. So even kind of from the very origins of like the field of gynecology in the United States, like there was this aspect of racism and like not just inequality, but overt like kind of
slaves can handle pain more.
Right.
Better
Yes,
or
exactly.
something,
So
all these sort of
yeah,
ideas.
there was this perception that Black people did not feel pain to the same extent. He didn't actually do these surgeries on white women until anesthesia had been more established for surgical use. So he didn't specifically say that, but at that same time period, it was well published that people thought that slaves felt less pain, could handle more physical, stress and discomfort, and that currently is still a perception. So there's actually a recent study from just a few years ago where they polled medical trainees, students, and residents, and a huge percentage of them actually thought that that was a medical fact, that Black people had like a different, density of nerve endings, that they had different pain perception, which is obviously not true biologically. And several studies have shown that Black people are offered less pain medication for overtly painful things like appendicitis, broken bones. So again, that sort of legacy is still present.
And more Black women die in childbirth.
Yeah, exactly. The Black maternal mortality is markedly higher, like I think like 3 to 4 times higher. It's 4 times higher in the UK. And even if you account for things like access to medical care, like education level, income level. So for instance, some very famous women like Serena Williams have said that they really had to fight for care. Like Serena Williams had a history of pulmonary embolism, can kill you. She knew the symptoms, and then she postpartum was like, I think we need to get testing. I'm really having some serious problems here. She had to fight to get that testing done, and she did have a clot. So yeah, regardless of, how famous you are, how much money you have, these inequalities exist.
All right. So to kind of wrap up where we're at so far, you talked about how early on medical folks focused on the body when they thought about hysteria. Then it kind of shifted over in the 19th century to the nervous system. This is when the rise of neurology happened. You mentioned some of the treatments like rest cure. They would say there's a nervous system problem here, so take rest. Electrotherapy was developed here to treat women, especially white women with nervous exhaustion.
Exactly, yes.
The diagnosis they would give, right? Instead of just societal misogyny and sexism is just wearing people out. That's maybe but no, let's put them in a bed and shock them. That will,
exactly. Oh, gosh.
But there's some is this true? Maybe I'll run this by. I heard that the vibrator actually was also developed at this time as a way of medically treating, which is one of maybe a good positive development.
Yeah, so and again, I don't know the exact specifics, but that's my understanding that the vibrator was used in this way. I actually have seen, when I was doing research, I saw some graphic, and it's a drawing of a woman kind of with water, a stream of water being aimed at her genitals as part, a similar idea, kind of stimulating the genitals in a certain way, would treat some medical ailment. So, I'm not sure exactly how accurate, if these are sort of myths, but I've heard that in the mix of all these kind of negative things, that one good thing was the rise of the vibrator. So,
the gatekeeping wasn't great. You had to get a doctor would have to do it.
Right.
But,
Exactly.
So, all right. So body, nervous system, and then mind. You mentioned Freud. This is the idea that hysteria is connected to some kind of psychological problem.
Yes.
And you say that also persists today. That women and people who are assigned female at birth will often hear that, this problem you're having that I can't quite figure out a medical diagnosis for. Maybe this is something in your head.
Yes, exactly. And so you kind of take this whole journey from, it's your uterus is broken to like it's your nerves. And now it's like it's just, manifesting your anxieties. And yeah, that definitely is seen today for sure. So in the book, I mentioned there's, a whole category of mental health disorders they call like somatic disorders, somatoform disorders, where it's like that there's no physical cause that's found. So we just assume that it's being manifested as like some sort of psychological issue has kind of turned into like physical symptoms. And it's like a 10-to-1 ratio women to men who are diagnosed with these.
Yeah. Oh,
and, when you kind of break it down, like a lot of times when women are told, oh my gosh, we can't find anything, everything is normal, like maybe it's that you're just too anxious, we'll find things like endometriosis or autoimmune disorders. And it's just that they hadn't found the cause yet. And so a lot of these things that are, the somatic disorders, like probably are that there is something physically there. We just don't know it yet. And a lot of the women's health issues I talk about in the book don't have an easy diagnostic test. So doctors, we really like facts. Like we like kind of hard facts. So like an EKG that's abnormal, a blood pressure that's abnormal, blood glucose, but there's not an easy test.
Cyst or something.
Right, yeah, something that we can see. But endometriosis is usually not seen on imaging. It's so small, usually you can't detect it. There's no blood test for it. Same thing for like premenstrual dysphoric disorder. It's just based on what someone is saying that they feel. There's no like objective test. Pelvic floor issues, so all of these things, we sort of just take the person at their word, based on what they're experiencing. We can't see it in like an objective medical test. So that leads to a lot of these delays of diagnosis where someone runs a bunch of tests and then they say, oh, actually, well, everything looks normal, so there's nothing wrong. That actually very, very commonly gets told to people, especially women, people assigned female at birth. Everything looks normal. I'm making the air quotes. So therefore, everything is normal and ... whatever you're experiencing must be mental or emotional.
Okay. I'm glad you're taking us here because people can be shocked by the history that you talk about in the book. It's not hysteria. And they can wonder, how could people ever believe such weird things or be glad that we don't live in such unenlightened times? Right. But you're also quick to point out in the book that we still haven't reached the promised land. Yeah. There's still a lot to learn. And the modern medical system prides itself, like you said, on being evidence-based, using research studies to guide diagnosis and to prescribe treatments. But you also say that research itself over the past 100 years has also been skewed against women. Let's talk about some of those problems that have persisted to the present.
Yeah, exactly. And I always say, it's not like the doctors are intending to be misogynistic. I'm a gynecologist. I don't think that gynecologists are by nature like bad people. It's just the system is so skewed. We have so little data. We have so little actual research on these things that kind of into that space of lack of information has sort of come all of this, like these myths and things and people being managed in a way that isn't as medically accurate as we would like it to be. So part of that problem is, why is there so little research?
Yeah.
So for instance, formally, there were actually restrictions on women being included in medical studies in the 20th century. So the NIH, the National Institutes of Health, which is the major funder for medical research in the world, did not require that women be included in studies until 1993. Wow. There were several major studies of groundbreaking studies on things like cardiovascular health that did not have any female participants. So this is where a lot of times what we think of as facts and are promoted as facts and like this is how we counsel patients are only based on data for men. So it's actually recently when they start to study women specifically that things like heart attacks manifest in very different symptoms in women and men. Cardiovascular disease patterns are very different for, say, postmenopausal women, premenopausal women, and men. But we don't have so much of that information because they just weren't studied. And then in terms of medications, the same year, 1993, there were actually many decades before that the FDA actively excluded women from being included in early drug trials, early phase drug trials because of fear of birth defects. So, after the whole thalidomide issue, they were just almost too extreme, being like, we should just have no reproductive age women in these studies.
At all. Yeah.
And it said it didn't matter if they said they were not sexually active, if they were a lesbian, if they were using birth control. It did not matter. They just excluded everyone of childbearing age. So then again, we don't have information on how medications affect women because they didn't study it.
This kind of exclusion, you give example after example, and I was also really surprised by the disparity in funding.
Yes,
So,
yeah.
for example, you say that the National Institutes of Health allocated $84 million for Crohn's one year. No shade to any of our Crohn's
course,
folks
yeah.
out there, but that impacts about 0.21% of the population. So $84 million for 0.21%. Compared to $27 million for endometriosis, which you say impacts up to 10% of women. So so these huge disparities in funding are pretty surprising.
And even more striking, so fibroids affect 70% of white women, 80% of black women. Now, not all of them will have symptoms, but I mean, that is a massive percent of the population. Fibroids has a fraction of the funding of endometriosis. So
you said 15 million in the book.
Orders
I was
of
like,
magnitude
what?
less than some of these other conditions. I actually just did an interview for the Times in the UK, and the reporter actually went and did some more looking up of these NIH numbers, and she found like similar kind of scale of difference for something like lupus. Lupus is obviously a very serious condition, as is Crohn's. It's not to say that they're not serious. It's just that they get way more funding. Again, sometimes orders of magnitude more funding, despite having a tiny fraction of the number of people affected compared to things like endometriosis and fibroids, which affect incredibly, like pain, like loss of work, really severe issues that affect people's quality of life. So it kind of goes to see what people in the medical system think of as serious, again, air quotes, medical conditions worthy of funding, worthy of research compared to quote unquote, just women's health. So because some of these are like, well, it just causes painful periods. Doesn't everyone have painful periods? That's not as serious.
And expecting people to deal with it.
Right. They're just supposed to deal with it as opposed to, but like lupus and Crohn's are really serious medical problems.
Yeah, they suck. That they suck for sure. Like there's no question that we want to like confront those things. But as you mentioned, the fact that so many women are dealing with just pain with their periods every month. And there's this baseline expectation amongst a lot of people that they're just supposed to deal with it. You also mention other things like physician specialists. There aren't enough of specialists being trained. That there's ongoing insurance discrimination issues. That there's provider burnout that happens. So there's a lot of systemic issues that are harming women's health.
Yeah, exactly.
But it's not just the system. There's some individual ignorance happening as well. And so I think your book does a good job to introduce people to the basics here.
Yeah.
And as you say, a lot of women feel afraid or alone or ashamed of any reproductive issues that come up. And a lot of men just kind of stay out of it. Not to mention non-binary folks or trans folks who are also trying to navigate gender identity while they're also dealing with all of these potential reproductive issues.
Exactly.
So I thought your book's basic breakdown of anatomy and sex ed was kind of nice. What were some of the biggest myths you wanted to confront there when you were just talking about the actual kind of plumbing down there?
There's so much. You just mentioned like 10 different things I want to address, which is great. Super quick, like before we move on too fast, the system issue is a huge one. And I think this is something that we as a society need to confront sooner rather than later because OBGYNs are burning out because of insurance, like reimbursement being so poor. I think this is part of the reason that OBGYNs only get like 10 minutes per patient. And there's no way to like actually like effectively diagnose and treat like all of these complex issues during that time. And then they burn out more and then they drop out. And then women have a hard time getting in to see a gynecologist at all. So it's a really very difficult problem I think we need to address. To the specifics of, like the anatomy and debunking myths. This is why I want not just women and people assigned female at birth to read the book, but everyone, because so many of the topics are not just related to just people who have them, but, it talks about like how does pregnancy happen? How does birth control work? Abortion?
What's a
gender?
period?
What's a period? If it's not affecting you, it affects someone
I've been married to a
know.
woman for like 18 years, and I kind of knew the basics, but didn't know. I'd learned a ton in this book alone about
thank you. I'm glad.
a lot more about what's going on.
Yeah.
Give us, for example, like a couple of myths about periods.
Yeah.
That you're like, all right, we got to confront these myths.
Oh my God. So number one myth is obviously, you already said it, that it's supposed to be bad. Everyone has a bad period. You just have to deal with it. That is definitely not true. It's very common to have just cramps, but if something is severely painful, that is not normal. I always say, even if something is common, it's not normal. So if it's affecting your quality of life, it's keeping you from working or going to school or having sex or exercising, like that is something to see your doctor and get an evaluation for. So that's very very important. And that goes for things too, like menopause. Everyone who's, like started having periods is going to go through menopause, but it's been this perception for for all of human history. You just had to kind of deal with it. It was like this shameful secret when you got to a certain age that, you just didn't want to talk about. You're going through the change. But now, so many people like Oprah, Drew Barrymore, like Halle Berry, they're speaking out because they're like, this is crazy. It's horrible. Like, we deserve treatment for this. We deserve medications and options to help us with this. So, I think it's great that we're finally debunking these myths that like, just because something is possible or that a lot of people go through, that you have to just deal with it and just suffer it, or is woman's lot in life,
Yeah.
And then like with other myths, I do a lot of social media. So on TikTok, especially, there's a lot of kind of funny videos that they will show a man like, a picture of the female anatomy and be like, where's the clitoris? Like point out the clitoris and they can't find it. It's hilarious. So again, part of this is like, I hope that men do read this because it is helpful just to know.
There's different holes that pee come out
that's
of
a
versus
big one.
the vagina.
What are the
and
holes?
the vagina is like, vagina isn't the whole thing.
Right.
Like that's the vulva.
Like what do the words mean? Like people think vagina means the outside, the inside,
the whole thing,
everything. It's only the internal canal. And the number of holes is funny, but it's apparently a lot of men don't realize how many holes there are. So there's this myth that, you can't pee with a tampon in, which it sounds funny, but it is kind of sad because if you don't know how the body works, if you have a partner, if you have like a sister, a mom, a friend, like you kind of can't understand what they're going through.
Yeah.
And then obviously recently we have, of course, like the political aspect, which is that we have people legislating women's bodies who don't understand how the bodies work. There's all these, you always hear in the news that some lawmaker thought that you could implant ectopic pregnancies back in the uterus, or they thought that IVF was X, Y, and Z.
Or there's a body can shut down a rape
is
or
that,
something.
if you didn't enjoy sex, that you can't get pregnant. So, there's all these myths that get perpetuated even among people with power to affect laws about women's bodies. Yeah.
Have you seen the algorithm impacting the reach
Oh,
on
horrible.
any of these? Like, do
It's
you
horrible.
see certain ones kind of take off? Like, what have you seen really take off when it comes to these
so
myths?
I'll say both directions. So experiences that people thought they were the only person, and they're surprised to find that lots of other people have that too. So for instance, some of my most viral videos about very kind of, on the surface, you wouldn't think it's a common thing, but when you see the comments, you realize a lot of people are going through this. So one of them was rectal pain with periods, like stabbing butt pain when you have your period. I've gotten like millions of views, thousands of comments being like, oh my God, I have that too. I thought I was the only one.
Is it the feeling of sort of like,
Like a stabbing
type thing, or like
a
an
stabbing
intense,
or shooting pain in the rectum? And that can be a muscle spasm, or it can be a sign of endometriosis.
And so people are like, wait a minute, this is happening to multiple people.
I
What happened?
know.
And then you see that
spreads,
spread.
because people are so amazed that they comment, they engage, they share it. They're like, did you know about this? Yeah. So those type of videos. Another kind of interesting one that went super viral, I was not expecting. There's something called a decidual sac, which is a phenomenon where literally instead of having a little bit of tissue come out with your period, like over several days, it comes out all at once at the same time. So literally you get...
When I hear decidual, I think of tree roots.
It's just like the little, like all of the tissue in the uterus comes out at once, and it looks like a blob, and it can be quite painful because it's so much is coming out at the same time. So people like bleed heavily, this thing comes out, they're really scared, they're in a lot of pain. So again, people are so freaked out about this. They're like, what is that? People even think that they're having a miscarriage. And it was my impression, that this was a relatively rare phenomenon. It turns out, having seen this video go viral on every platform with I can't even count how many millions of views this has on all the platforms.
Wow.
Thousands of people are having this and just not telling their doctor because they're like, what the hell is that? I don't want to tell anyone because it's so embarrassing or weird. So all of these things that are kind of shared experiences, I call it the emperor's new clothes phenomenon, where everyone's like, oh my God, like I don't want to make it sound like I'm weird because I had this crazy thing happen. But then once everyone realizes that the other people are having it too, they're like, are you serious? It's not just me, it's everyone, like so many people. So I kind of love that we're breaking down the silence and the taboo around talking about, bleeding, periods, pain, all of that stuff, because that does kind of keep people feeling like they're alone, like they're isolated. On the opposite extreme, things that are doing very poorly in the algorithm are anything using the correct terms. So literally, if you say vagina, It will get censored,
Yeah.
especially on TikTok.
I've seen
Yep.
you you put on captions. You have
You
to
have
like
to
put it
misspell the
different,
word.
so that,
Yeah.
leave out letters.
I know,
yeah.
it's terrible. And we've complained about this, like doctors have complained about this a lot, that we can't use the actual anatomic terms because it's felt to be,
Yeah.
it's dirty or it's sexual. Like, no, like I'm a
pornographic or
gynecologist. I
something,
should be able
yeah.
to say the word vagina in a post, an educational post.
Yeah.
I literally had I was on Jonathan Van Ness's podcast, and at one point we literally just said the word vagina a bunch of times just to say, like, it's just a word. Like, there's nothing kind of dirty about it. You
Yeah.
can say it. And I put a clip of that on TikTok, and it got like no views. Like, it literally, you could see the
Wow.
difference in the suppression. Like, it was actively
Yeah.
suppressed by the algorithm. And so, I mean, it's ironic because we were just saying, like, we should be able to talk about this in a public forum.
Yeah.
A nurse actually just told me that her daughter, her 5-year-old daughter, the kindergarten teacher called the mother and was like, your daughter was saying bad words. And they didn't even say it. It was so shameful. They couldn't even say the word at first. They were like, she said a really bad word. And the mom's like, oh my God, did she say like the F word? Like, what happened? And they said, she said vagina. Like that girls have vaginas. And the nurse was like, are you serious? So even from that young age, like, it's so perpetuated and ingrained that it's dirty, it's shameful, it's embarrassing. Don't talk about it. And that gets internalized. Like, people think, oh my God, it is shameful. I shouldn't talk about my body. I shouldn't talk about sex or like what I'm going through, discharge, periods, leaking with urine. Every woman, every person that's had at birth, everyone with a vagina has these experiences, but somehow it's become so socially ingrained that you just don't talk about it. And that's why I wanted to write the book too, was to get people talking. Like, my greatest hope is that people will like read this in book clubs and talk about it with their friends and realize that they share these things with everyone around them and they just didn't realize.
For people that want to follow your stuff, they can follow you at TikTok, Instagram, you're on YouTube. It's at Karen Tang MD. That's where you're found. And again, we're talking about the book, It's Not Hysteria, everything you need to know about reproductive health, but we're never told. I imagine, it can be frustrating when you can't say particular words when you're trying to do public education about it. On the flip side, do you also find yourself having to battle misinformation on those platforms? Because anybody can start an account and anybody can become an influencer if they have a certain look, if they have a certain vibe, they can make certain claims. There's a lot of anti-COVID stuff. And there's ways to spread misinformation too. Yes. Do you find yourself having to kind of work against that type of misinformation as well?
Of course. Oh my God, so much. And the problem is that the algorithms do favor misinformation, because if it's shocking, if they propose something in a very shocking way designed to get a response like that, if people comment, if they share it, did you see this crazy thing? It will spread like wildfire.
Well, the platforms want attention capture, right? Like,
they
the
love it.
goal of them is to keep people there. So whatever does that, whether it's true or false, that's what they're more likely to put in people's feeds.
Exactly. They will boost the hell out of misinformation videos. It's very, very hard to fight misinformation because they're so effective at gaming the algorithms. And the problem is that, especially in kind of the pseudoscience space, like, anyone can put the word doctor in front of their name, make claims. And if they say it in kind of like a sciencey or authoritative sounding way, then people are like, oh my God, like, it must be true. And when you look at it, they're like a doctor of like a chiropractor, or like a lot of them get these like online PhDs that have nothing to do with health. And then, but they call themselves doctor all over the place. Usually, if you look into their websites, they're selling expensive supplements, courses, the coaching, all this garbage, and basically just making lots of money profiting off of misinformation. A lot of times they do it by making people scared, and they say like, oh my God, like, for instance, like in my space, like, birth control is poisoning your body. It's poison. It's dangerous. And so women are like, oh my God, I don't want to, I'm taking birth control. Is it dangerous? And then they'll say, you have to take this like detox supplement. So people will flock to that kind of thing because they're so scared. They're like, oh my God, this legitimate sounding person like is saying this horrible thing. I'm like, I don't want to hurt my body. So it is very difficult because cold hard facts like are very unsexy. It's very hard to kind of go viral with like, let me just tell you the bare bones facts from what we know about research studies.
And here's what we think too, right? Like, sometimes medical science
know.
is humble. And so,
And we have to be very transparent about that. We have to say, like, we just don't know. We don't have a great answer. This is the best we know. And that doesn't sound as attractive as, I have the answer and it's going to fix your life. Just sign up for my course, blah, blah, blah. Like, so it is very hard to compete with that. I only started doing social media like maybe 4 years ago, like just pre-pandemic. I didn't know how to use Instagram, TikTok, all this stuff. Other doctors who had started in that space had said, like, we need to get on there as medical professionals because we
Yeah.
need to try and kind of fight some of this misinformation. It became very important during COVID because of the misinformation about, vaccines and masking and social distancing. There was so much misinformation out there.
Yeah.
So the medical profession, just as a whole, is very far behind the curve, behind some of these influencers who have learned to monetize
Influencers, yeah.
all of the misinformation.
Yeah, I encourage people to look into people's credentials. I
Yes.
encourage them to seek medical consensus. It's not always going to be right, but
Yeah.
I'm not a specialist enough to say that I know better than the consensus, recognizing that the consensus isn't always perfect. So, and looking at what people are trying to sell me.
Yes,
Those are
yeah.
kind of the assessments that I make.
That was perfect. Yeah, that was a perfect summary. I will say, yeah, look at their credentials, look at where they may have a conflict of interest in selling you something.
Yeah.
And then number 3, if they are saying something different than everyone else, there's a reason. I always tell people, like, nothing in medicine is black and white. Like, no one is 100% right all the time. No one is 100% wrong all the time. If someone's saying that I know more than every other specialist who has devoted their entire life to doing the research and trying to analyze the data, they're all wrong. I'm the only one who knows. Like, that clearly is usually completely wrong. And so
The other problem I see with these outliers is they're not involved in the ongoing work with other people. So their claims aren't being vetted. They're not being peer reviewed, a lot of them. And so that's another thing. But you personally, you came to try to do the influencer thing. You've gained a following there. But I'm wondering about just your decision to become a gynecologic surgeon to begin with. Why was this your field? Like, what drew you here?
Yeah, it's interesting. So I didn't know, at the beginning of my training that that's what I was going to end up doing. I was actually quite scared of surgery. Like, I think a lot of women, especially, like, it's very intimidating. It sounds like it's a very, like, hierarchical system. Like, there's going to be a lot of like yelling and intensity.
We've all heard things about surgeons.
Oh yeah, surgeons like throwing stuff, and it's like very high stakes and very nerve wracking. So I knew I liked kind of talking and counseling and teaching people. Like, teaching has always been part of something that I really felt was important and I valued. And I thought I was going to do primary care for those reasons. And then I did a master's in public health, and during that time, everything I wanted to study was women's health, reproductive health. So I was like, okay, clearly, like, the OBGYN became the front runner. And then when I think a lot of people don't realize that OBGYN is a surgical field as well. Like, we do surgeries for all of like the women's health, but I didn't know that until I was a medical student. I was like,
I didn't know until I read your books.
Yeah, I know. I was like, I didn't know that.
I mean, I figured surgery was involved, but I didn't think about the specialization that would happen.
No. People think of like pap smears and babies. Yeah. So it's a very diverse field. And so when I was doing my residency, I didn't realize that there were subspecialties of OBGYN that were surgical. So, gyn oncology, where they treat like ovarian cancer, uterine cancer, urogynecology, which is for like things like prolapse, incontinence. They do the repairs of those. So it's almost like a combination of urology and plastic surgery with like reconstructing the pelvis. So, and my field is minimally invasive surgery, like, doing minimally invasive surgeries for endometriosis and fibroids and cysts. So, there's a lot of surgical fields in gynecology. And I was like, oh, I was doing the rotation. I was like, I'm actually really good at this.
Yeah.
I was a violinist, like,
Cool.
trained with my hands. And I was like, oh, this is actually really fun. And it's great to be able to have a tangible result for people, like, relatively quickly, that, you can do something and see a result pretty much right away. And that was really great. So, and then plus, as a gynecologist, we can have that longitudinal care. We can counsel people. Like, I counsel people on like menopause, PCOS, birth control, sexual health. So it's a great field. I think it's really great. It's tough because of all the social issues that we're facing nowadays.
Sure.
But it is still, I think, one of the best fields. Obviously, that's why I went into it.
Yeah, you're also paying attention to intersections a lot. I mean, you're a woman of color yourself, so you're attuned to how the medical field and medical experiences often differ by race, and how racism can get involved there. And you've also experienced reproductive issues you talk about in the book, including miscarriages and other things. Right. So you're in the mix yourself.
Yeah. Being someone who has gone through a lot of these things, I think like every woman at some point has had one of these issues in the book. So, the bladder health issue, again, like no one talks about this, but I mentioned like 75% of women who are, postmenopausal at some point will have leaking of urine. If you've had a pregnancy and given birth, you leak urine. So all of us, we kind of joke, and when we see other moms at like the trampoline park at children's birthday parties, we're like looking at each other like, we're not doing that.
Yeah.
So it's not just like writing an encyclopedia. It's writing about from the experience of someone who's kind of gone through some of these things or has heard the stories of people who've been through it, if I haven't been through it myself. With the intersections, like you said, like I wanted to make sure I included, transgender, non-binary people, intersex people, because they are kind of left out of these conversations a lot, and they obviously are affected by gynecologic issues. So I made sure that, I had expert readers and sensitivity readers who were helping me with those chapters. My book tour event on Tuesday at Harvard Bookstore is with Skylar Baylor, who's a transgender man who is an excellent educator in transgender issues. And we've had some great discussions on YouTube and Instagram about kind of shared topics like going to a gynecologist as a transgender person and the experience of that, and how do you advocate for yourself. So it was very important for me, again, that this book wasn't just like, here is just an encyclopedia of some facts about the uterus, but about the experience of people who go through some of these problems. Like, what challenges do they face? Like, what questions could they have? Like, how do they find the right solutions for them? So yeah, thank you for that question. I thought, I don't think anyone's ever kind of brought up like the intersections and, me as a person, like as a human being.
No, it's so
going
important.
Through. Yeah, it's super important.
You mentioned the being inclusive about gender too. There are sections in the book that specifically speak to that, but also you signal to that throughout the book. So you don't like silo it off as though it's this, and there's also this other thing, but you use inclusive language. So that throughout the book, it's just a normalized part of it. So I really appreciated that. Remind people the name of the book is It's Not Hysteria, Everything You Need to Know About Reproductive Health But Were Never Told, by Karen Tang. She's a board-certified gynecologist and a minimally invasive gynecologic surgeon and an internationally recognized leader in reproductive health. You may have seen her work featured in places like the Washington Post, Self Magazine, NPR, and elsewhere. And she's joining us from Philadelphia, where she lives with her husband and 3 kids out there. So let's talk about exams and procedures. The later part of your book is helpful. I've never been to just a straight up gynecology appointment with my partner, right? Sometimes she'll talk to me about stuff that went on there. But this was great for me to just get the basics of it. And also, I think even for women who go, to kind of be able to triangulate. And I'm sure women often will talk to each other about how their visits go. But you walk us through a routine visit. So let's talk about the tips that you give people, what they can expect at an exam so that people can make the most of their time. Because like you said, sometimes these visits go way too fast anyway. So that's a great question. And it's so important because I mentioned earlier that some of these OBGYN appointments can be very fast, like 15 minutes, 10 minutes. So the first thing is actually to tell the office when you're even just scheduling the appointment, if you have a lot of concerns, like you're specifically having like pain or period issues or many questions, menopause, tell them that when you schedule, because sometimes people will book what's called like just like an annual exam, like a checkup. And those are extremely short visits. Like there's just not enough time to cover a lot in them. So what happens is people like show up, they wait for their appointment, and then there's like literally no time to discuss anything. It's basically like quick questions, a pelvic exam,
preventative care, pap smear, breast exam. Exactly. So number one is just make sure you tell them when you schedule what your issue is, and like kind of ask about the length of time. There's certain kind of appointment times that are longer than others. And then obviously reading the book, preparing your concerns, your questions, having things organized. I have a chapter in the book on like what you're going through, what symptoms you're going through, your period, so you can have everything kind of organized and ready to go to share with your doctor. So it's not that they're spending a lot of time kind of trying to just like pull all the information out and a long kind of lengthy way. And then also having an idea of what some of the options they might present to you could be and what your thoughts on them are. So for instance, like, what do you think about birth control? What do you think about surgeries, procedures? Right off the bat, if you can say, like I'm a little bit nervous about, hormones, or I really don't want to do anything surgical, like it can help the doctor kind of focus the time in their counseling. And then in terms of the exam, how to make it more comfortable is, usually, hopefully this way in every office, but it may not necessarily be. The doctor should talk with you before they're like doing any sort of sensitive exam. So you should be able to have time to talk face to face, without being like literally up in the stirrups. And I think people sometimes, if they're just literally like in the stirrups, they're feeling vulnerable, they just don't feel comfortable like sharing a lot of things at that time. So you can ask too, like, will I have a couple of minutes to talk with the doctor before we're doing the exam, just to make sure that you can get like your concerns out there in a comfortable, safe way. And then with the actual literal exam, I talk through like how to make it more comfortable. It's, it's like the dentist where we're like, okay, it's like, it's not everyone's favorite thing to do, but there are definitely tips and tricks for making it, the least uncomfortable and smooth as possible. So we talk about like the pelvic floor muscles, like kind of little things to kind of just relax them before you have an exam, because it can be more uncomfortable if you're tensing everything.
Well, and some people have conditions that vaginismus.
Yeah,
I think
vaginismus,
is one of the-
vulvodynia.
yeah.
So
Yeah.
also, obviously definitely feel comfortable sharing with your doctor if you have a history of trauma, like if you've had, some sort of
Yeah.
experience that makes them more difficult, like emotionally or physically. We obviously take that definitely into consideration. So feel comfortable
Because they'll
sharing
basically
that.
like clench up, right? There's
Yeah.
like a
It's like the
reaction
muscles tense
because of trauma.
Yeah, exactly. It's an involuntary tensing of the muscle. Make sure that they tell, because sometimes we will actually give people, like a Xanax or something. Now there's more use of things like nitrous oxide for exams if people are nervous or uncomfortable. So we talk about that as well.
So for guys and people who haven't done this,
Mm-hmm.
like even just give us a quick description of what that actual pelvic exam is. Like
Sure, yeah.
What happens at that moment? Yeah.
So there's different components of it. So we don't always do all of the exam on every patient. So for instance, if someone's in the ER with an issue, they sometimes think that they had a pap smear done, but that's not necessarily true. So, pap smear, which people have heard of usually and equate with the entirety of the pelvic exam, is just a test for
need to
cervical
rename it.
cancer. Yeah, exactly. So a lot of people think that it's synonymous with the whole pelvic exam. It's just a portion of it. So a pap smear is basically just taking a soft brush and touching the cervix to check for cervical precancer or cancer. It's usually done with a speculum, which is a little duckbill thing that opens the walls of the
Yeah,
vagina.
it's like a little puppet looking
Yeah,
thing,
yeah. So you can see the
It'll hold
cervix,
it
which looks like a
open.
donut at the end of the vagina. And we don't necessarily always do a speculum exam. So, for instance, things like if we're just checking to see if anything hurts or signs of infection, sometimes we can do that with just like a vaginal swab, or we can check with the fingers to feel the size and the shape of the uterus internally. So those are kind of like the components of it. We also check like the skin of the vulva. So, we're looking at the vulva, the vagina, the pelvic floor muscles, the uterus, the ovaries, some combination of those. And so the whole thing is usually just a few seconds. Like I'm pretty quick with my exams. The whole thing probably takes less than like 1 to 2 minutes. And so people think of it as like this long drawn out process. It really shouldn't be. And then we don't necessarily do every exam at every visit. So again, it's important to kind of talk with your doctor, like what tests are you going to do today? Like what's it for? Like if you're
Maybe
concerned.
they'll do an IUD insertion
Yeah,
or
so we
something.
talk about IUD insertions and kind of pain control methods for that. That's gotten a lot of talk on TikTok and stuff. And to be fair, like I think in the past, like gynecologists really just were not great at counseling about different pain control options. I'm a pain specialist, so I've always kind of I've talked about it more than most people. But now there's actually really a focus on making it comfortable. So a lot of gynecologists, for instance, are getting like nitrous oxide systems, looking at things like putting local anesthetic like into the uterus with like gel or straw, because the numbing medicine shots are actually kind of painful themselves. So we're trying to think of like creative ways to make things like endometrial biopsies, which are biopsies of the tissue inside the uterus, IUD insertions, colposcopies, which are tests for abnormal pap smears where we take biopsy of the cervix.
So you're actually taking a piece of
Like
the
a
cervix
small
out to like
piece of the
test it for
cervix.
cells.
Yeah. We're trying to be more purposeful about pain control options and making it as comfortable as possible for patients.
One of the things you emphasize over and over again is that you really want people to be willing to ask questions and to advocate for themselves. It also made me wonder, though, about patients who might be afraid to make ultimate decisions about something. Maybe you encounter patients who just want the doctor to make the decision for them. And what's your suggestion about that kind of scenario? I imagine I might be that type of a person to be like, well, just tell me what to do. I
Yeah.
don't
Oh,
know.
and that's totally fine. Actually, in one of the last chapters, it was sort of like, well, what do you do now? Like, how do you talk with your doctor? And I actually say this, like, some people are like, look, I just want the doctor to tell me. I don't want to have to, like sift through different reams of information. I want you to use your expertise and just kind of like tell me what you would do. And patients ask that all the time, like, what would you do if you were me? And then that's absolutely a valid response. So I tell people it depends on kind of what your preference is. So some people want to literally vet every piece of information. They want to look it up themselves. They want to look at the study. A lot of engineers are like, it's sort of like this kind of famously like engineers like just want to see the data. Like they're like, give me the link to the study. I want to look at it myself. And then some people are like, well, I'd like to just kind of like take my time and like reflect on it. Like maybe ask some friends or my husband, like ask somebody to kind of bounce the ideas off of. They don't want to decide right then. And then other people are, like I said, I really just feel more comfortable, doctor, if you just tell me what you think is best. And it's all valid. So all of those are perfectly great ways to go about it. It's just most important to figure out what's right for you. So where people like feel like upset or disappointed is sort of like, they're like, this is just really not a good fit for how I want to do this. And sometimes I tell people it's great to do second opinions, third opinions, if you're just like kind of not a great fit for the way that a particular doctor does things. So it's not like dating. I don't want to say that, but like it is about finding a fit. So, doctors are human beings.
Well, I think of therapy in the same way. Is like you want to find a therapist
like people will try different therapists.
With,
Exactly. Like there's sometimes just like a better communication style of communication is different.
Yeah.
So again, doctors are human beings, so we have ways that we communicate or ways that we do stuff. So it is important to feel like you are with a doctor who is communicating with you and working with you in the way that you feel most comfortable.
Karen, it's so helpful to hear all this. Like I said, these are appointments that I haven't really taken part in. When my partner was pregnant, I went to a lot of appointments and kind of got to know some circumstances there, which was really fascinating. But when it just comes to basic reproductive health, myself and probably a lot of men in particular, I don't think have been as plugged into this. And I think it's important and useful if we would get more plugged in. And then, as you said, sometimes it's taboo for even women to talk about some of the things with each other. So the kind of work that you're doing, I hope, can really spark more conversations about this stuff.
Yeah, that's my hope for sure.
Let's maybe dig into a few specific issues, just as an example of some of the things you touch on in the book. So, for example, you've mentioned fibroids a number of times. Maybe just take 30 seconds or so and describe what those even are, because as you said, they affect up to 80% of Black women.
Yeah, and so many people haven't heard of them. So they are benign tumors, meaning they're non-cancerous masses that grow in the wall of the uterus. And a lot of times they're small and they don't really cause too many problems, but they can grow bigger, they can push into the cavity of the uterus, and so they cause a lot of really severe symptoms in some patients. So for instance, they can cause lots of bleeding, like to the point of like hemorrhaging, like ending up in the emergency room getting transfusions level of bleeding.
Oof.
They can cause severe pain, especially with periods, and they can grow so large they almost cause like pregnancy-like symptoms. So they can push on your bladder, make you need to urinate a lot, or push on your rectum and cause constipation. They can grow literally like to fill the entire abdomen. Someone like looks pregnant. And they can affect fertility because if they compress the cavity, they can prevent implantation of a pregnancy or they can cause miscarriage. So I always kind of make this example, and I said this in the book, like if something affected 80% of white men and caused hemorrhaging, severe pain, emergency room visits, and infertility, can you imagine that no one would know what it was? Like that there was no, we don't know what causes them. Like we don't know where they come from. Can you imagine that we're just like, we just don't know where they come from? Like no one knows. It's a mystery. There would not, we would have it like a global pandemic. Like, all of the national, medical societies would be like banding together to fight it. And so, the fact that it, mostly affects Black women, it also affects a lot of white women. Like I said, 70% of white women may have it. But just the injustice of the fact that like no one knows what they are is pretty illuminating. And I actually was just on NBC News, and the reporter who interviewed me for NBC's News had been on various, like Today's Show. She had given interviews because she had fibroids, and it took going to an emergency room hemorrhaging for her to get a diagnosis.
Wow.
And she's obviously very tapped into health. Like she covers health topics all the time, and actually had a family history of fibroids. So they run in families. A lot of these things like endometriosis and fibroids do run in families. Sometimes people may not necessarily know that there was a history of fibroids, but what is very commonly said, people are like, oh, my mom had a hysterectomy, my grandmother had a hysterectomy, like my sister had fertility issues. I'm not sure why. That's a very suggestive story for both fibroids and endometriosis. So people will say this all the time, like, I don't know why they had all these hysterectomies, but they did. They were having miscarriages, trouble getting pregnant. It's usually either because of endo or fibroids, and just it wasn't talked about. So.
And with endometriosis, you also say this is where the mind and body connection can be considered here. That you say people shouldn't dismiss a patient's emotions because having stress and having issues can exacerbate something like endometriosis. What's happening there, and what are some of the treatments that options people have when it comes to like fibroids and endo?
Yeah. So the mental health component is very important because it's so often that, it's like a chicken or the egg, that because these things are so stressful, they experience depression and anxiety, and depression and anxiety worsen pain. They worsen muscle spasm, which is associated with both of them. The muscles get inflamed by endometriosis or fibroids and tighten up and cause pain. So, the more stress, the more muscle spasm, the more pain, the more stress. And so, all these things kind of become these cycles. And so when I counsel patients in the office, I do say, we need to break the cycle. So not only are we talking about treatments for the fibroids themselves, just the endometriosis, just the fibroids. I'm sending them to a physical therapist, like a pelvic floor physical therapist. I'm sending them to a mental health professional, to GI doctors, to, bladder specialists, because each of those things needs to kind of be addressed in order to break these cycles of things just influencing each other. And with fibroids, very important to point out, obviously we don't have time to go through every single treatment, but what happens a lot with these is that patients are only really given one option. So for fibroids, it tends to be something like a hysterectomy, which is taking the whole uterus out. That is what we call the definitive management, meaning that, yes, if you take the whole uterus out, the fibroids are gone, they can't come back. But obviously, if someone is a young Black woman who wants to get pregnant in the future, that's not the right choice. But sometimes people will be presented with only one option, like you can only do a hysterectomy. You have too many fibroids, we can't do anything else, it's got to be hysterectomy. I always tell people there's never one answer in anything in medicine, including for cancer. Like, cancer doctors don't say this is the one and only choice. There's pluses and minuses and ones that are clearly like more beneficial for certain situations. But if you are being told that you only have one option and they don't give you any other options, that's where it's important to see a second opinion with a specialist. So there are people who specialize in fibroids, people in my specialty, which is minimally invasive surgery, where we do, a whole range of different treatment for fibroids. So if you are only being given one treatment, then please do seek a second opinion. It's interesting because for so much of these issues, like, it skews in the opposite direction. So either you're told you can only get a hysterectomy, or if someone wants, say, a sterilization or hysterectomy, but they're child-free and they don't want to have children, then they're told, well, but you might change your mind. And so they take away that choice.
Yeah, you say there's a lot of control that's happening.
There's a lot
here.
of control issues. And also this perception that if you could be pregnant, that you should want to be pregnant. So there are sometimes people want to have a hysterectomy or want to get their tubes tied, and they're told, well, but you don't have kids yet, so you're going to regret this later. I refuse to do that. So it goes in these wildly extreme opposite directions sometimes with gynecology, where people's choices are being taken away. So it's all about choice. Like, everyone should be given options so they can find the right choice for them.
Yeah, and the options are going to have different possible side effects or outcomes. There was a moment in the book when I thought, man, this particular thing that Karen's describing sounds so terrible. Why don't we just remove ovaries for anybody that is experiencing this? And you go into the point of like, well, that can cause cascading issues in other ways.
Terrible
like
health issues.
It's a complicated, so it's a complicated decision to make about a hysterectomy or removing ovaries. Like, these can have other repercussions on someone's health.
Yeah, kind of going back to the history thing, I actually just did an interview about hysterectomies and how in the past we did used to, as a field, just take out ovaries much more like freely. Because just like you said, like, well, why not? Like, it'll prevent X, Y, and Z. It'll prevent ovarian cancer. But obviously, taking out your ovaries and causing a sudden surgical menopause can cause lots of health issues. It can cause, not just the hot flashes and vaginal dryness stuff, but cardiovascular disease, osteoporosis, loss of muscle mass. So all sorts of health issues. So I think, in the past, again, people thought that exact way. They're like, well, this is terrible. Just take out like everything.
Yeah.
But obviously now we know that there are health ramifications for all of it. So we have to balance all of the risks and benefits whenever we think about choosing a treatment.
Right. And when you mentioned menopause, I mean, I kind of assumed that once periods end with menopause, that there was sort of a Shangri-La waiting, like this is like a time for people to just be done with like kind of, but you say there's a whole new world of changes and possible medical problems.
Issues.
So no, and I couldn't help but be like, my gosh, like, can't women just get a break?
Yeah, I know, right?
They're not getting a break.
Yeah, the chapter on menopause starts with like, if you're dealing with like horrible periods and PMDD and bleeding, you may think that it's like the promised land is when it all stops.
Yeah.
But then of course, like I just mentioned a bunch of the symptoms of menopause, but like including things like, brain fog, problems with sleeping, decreased libido, increased UTIs, a lot of things that people don't realize are menopause symptoms. It really affects a lot of things.
And you're encouraging people to try to take some action there if they're experiencing these things, if there's things that
absolutely.
people can do. So
Exactly.
you're giving people a heads up of what they might expect, but you're also saying, look, there's some things that can be done.
Absolutely. And what I love is actually in the last 2 weeks, I feel like I've had an influx of women who are perimenopausal. Like they haven't had their periods fully stop, which is menopause, where it's been more than 12 months since you had a period. But they're sort of in this time period where for a couple of years, things are changing. They're not quite sure what's going on. Periods are a little irregular. They feel some of those symptoms. And now that people are more aware of perimenopause, menopause, they're coming in earlier. They're saying, I just want to nip this in the bud before it gets worse and before I'm really suffering. I want to take control of my health. And I think that's fabulous. That's the exact goal, is that for people to be aware and educated and empowered so that they can kind of take control and not have to wait until they're just feeling like they're nearly dying of all of these horrible symptoms before they get treatment.
Yeah.
Because that's kind of what's happened until now, is that you have to be dying in pain or hemorrhaging, or literally can't function with hot flashes before you get treatment. And again, not that that's because individual doctors are being purposely mean, but that's just the culture. It was you just have to deal with it. And if you can't deal with it anymore, then that's when you should get help. I'm glad that we're breaking that myth that, you can get help when things are just starting to be bothersome. That's the perfect time to get help. So for endometriosis, earlier on the diagnosis, the better. Don't wait for it to be horrible. And as doctors, we should be jumping on these things much sooner too, so they don't spiral and become severe endometriosis, infertility, debilitating menopause symptoms, all of that.
For me, one of the more discouraging sections was about PCOS, just because it seems to be one of the most mysterious ones. Is my impression right on that?
Yeah, the PCOS is, again, one of these conditions that it's not even one specific disease. It's just a group of symptoms. So if you have
it's a syndrome,
2 out of
right?
3,
Which means we
syndrome.
don't know.
We don't know, exactly. So back to the problem of we just don't know. We don't know what causes it. Is it a gene, an enzyme? No one knows. So you just have to have 2 out of the 3 things: missing periods or very infrequent periods, signs of extra testosterone like acne or facial hair, and then polycystic ovaries on ultrasound, which is just teeny little cysts, which are basically just follicles holding eggs that just aren't being released regularly. And it's a very mysterious condition. It can cause skin changes, it can cause fertility problems, it can cause also metabolic issues. It's very highly associated with diabetes. So it's 70-75% of people with PCOS will have insulin resistance or diabetes. They can have high cholesterol and high blood pressure. So it's just such a wild condition because it affects all of these things. And again, no one knows where it comes from. So you can't prevent it. You can't treat the root cause of it. You can just sort of chase some of the symptoms of it. So we can give things to regulate periods, give things to induce ovulation for fertility, help with the diabetes stuff. But nobody knows the origin, so you can't address the origin, which is the problem with a lot of gynecologic issues.
This was the only hard part about reading the book was there's so just
sadness
having to confront so many of the things. I also think, though, the book is really helpful because people can dip in and out of it. It's not written as though you have to read it front to back. There's clear sections in here. If you want to look up something about PMS and PMDD, you've got a section on that. If you want to look up, there's a couple of important sections on abortion. Talk about things like septic pregnancies and why access to abortion and outlawing those things is such a threat to women's health. And you also talk about gender-affirming care as well. And so for people that are interested in all these issues and more, they can check out the book. It's Not Hysteria, Everything You Need to Know About Reproductive Health, But We're Never Told. As we're wrapping up here, Karen, I think a book like this can become dated, right? There's new stuff coming out all the time. So what are you suggesting for people
Sadly, I say not for women's health. I wish it was. I say this all the time. I'm it would be great. It would be awesome if we rapidly made this book obsolete by having so many amazing, groundbreaking things in women's health. But I will say I've been practicing medicine for 15 years now. I finished my training in 2010 and I have seen very few groundbreaking things, their new non-hormonal medication for hot flashes, and then one new type of treatment for fibroids.
And that's it. Wow.
Nothing else. No other new medication classes. Nothing. Yeah, it's sad.
What can regular people do then to help shift the status quo when it comes to reproductive health? What are we supposed to do? We feel like we're just waiting on more stuff to come around.
So this is where just people talking, sharing, speaking out. I mean, I always tell people you never know who's listening. I say this, my publisher publishes Melinda Gates as well. And Melinda Gates just announced that she's going to be dedicating something like $1 billion to like women's health funding. And I have been trying, I've been like, publisher, hey, you also publish Melinda Gates. Can you please give her this book? There's always like someone somewhere out there who has the ability to contribute to funding dollars, who is a researcher themselves, who is in government, who can make policies, who works in an insurance company. I'm like praying that, you know, someone out there who has the authority and ability to make some actual tangible changes in this is out there listening. Or if they're not listening to me, that maybe somebody out there hearing us now, maybe if you speak or you have a colleague or somebody that you know, that it somehow reaches the people who are in the position that they can make a huge change. But in the meantime, most of us, I think just like the fact that so many people are talking about menopause has led to some important changes. The White House initiative on women's health and like dedicating billions of dollars of funding came about because the Maria Shrivers and folks who are hearing these stories about menopausal women and how much they're suffering got to the point that it actually made a huge change. There's a lot of advocacy groups, like for endometriosis in particular, have been very effective. There is a documentary I was actually just texting about called Below the Belt, and they've held screenings at universities with government, with like senators, and like Hillary Clinton is one of the producers on that.
So you feel like there's a movement happening right
There's
now.
a
like
movement.
Some things are moving.
Yeah. A lot of, you know, people are just so fed up. They're like, we've got to do something. And so that's speaking out, that's organizing, that's lobbying, you know, raising funds. So just as, you know, regular human beings, like that's what we can do. And then just the first step is just speaking out, sharing our stories, you know, saying that this is not okay. This is ridiculous. And then hopefully turning that outrage into something positive, like positive change. So, you know, sometimes like these interviews get very sad because we're just like, it's so bleak. But I do want to turn it into, I like how we're taking it to an optimistic place before we end, that we can make these changes. I do think that we have the power in our voices joining together and speaking out and fighting for practical things that will make a difference. And it is changing. I think, you know, a lot of OBGYNs are on board with this. You know, we're saying that we need to like improve access to pain control methods, improve counseling, be more nuanced instead of reacting so wildly to like the hormones are horrible, hormones are everything, that we should have more nuance. So I think that the more we are talking, we are making some good changes. It's a start. We're going to get there. So.
Oh, you're doing a lot of great work.
Thank you.
People can follow you on social media at Karen Tang MD is where you can find Karen. Also, the book, It's Not Hysteria, Everything You Need to Know About Reproductive Health, But We're Never Told. Before we get to the final segment, Regrets, Challenges, and Surprises, I did want to ask about the cover art. It's really beautiful. And did you have a hand in like putting that together, or maybe tell me something about that art on the front?
No. So yeah, for those of you who don't know, like in traditional publishing, the author is among the last to know about the cover. Flatiron, my publisher, was great. They were very collaborative. We actually went through about 4 different cover concepts, which are totally different. And they were very open to us, like kind of scrapping entire, that were like, that doesn't kind of fit well. This was, we all went, oh, like, for those who haven't seen it, I call it like the vulva flame or rainbow vulva. It's literally this very colorful rainbow colored flame, which obviously it looks like a vulva, the opening of a vagina. And I say that, you know, if you think of it as fire, think of it as like, you know, there's an element of pain, but illumination, you know, sparking change. And it's very eye-catching. Like when you look at it in a bookstore, you're like, oh my God, what's that book? And it's great. I recently, of course, I can't find his name now. I recently connected with the artist who does a lot of book cover art. And he actually did the same art for the cover of The Adventures of Cavalier and Clay, which is a completely different style cover. It's got like, I think, the Empire State Building on it, but it's just a very talented artist.
Cool.
And did a fabulous job with this. And I think it was like the perfect cover. It's interesting because the UK version just came out yesterday and it has a completely different style. It's just very simple. It's a lightning bolt. And it has the word period at the end of It's Not Hysteria. Like, it's not hysteria, period.
Yeah.
And the lightning bolt, they told me, I didn't know this, it was a symbol of like feminism and resistance in Europe. So I guess in Poland, the lightning bolt was used as like a symbol of like resistance or like, you know, reproductive rights. And I didn't know that. And so it's very interesting what these symbols evoke in different places. So it's kind of neat.
Well, let's talk regrets, challenges, and surprises. You can pick 1, 2, or 3 of those things. Basically, your book's just now coming out, so I don't know.
Yep.
that there's much to regret or that you wish you could have changed at this point, but maybe there's something? Or what was the most challenging part about writing it, or something that just really surprised you in the course of doing this project?
I will say, like, the most emotionally difficult part was actually in the trying to promote it. You know, again, I have an amazing publisher. Flatiron has published like some, you know, they publish Oprah, Matthew Perry, Elliot Page, like really heavy hitters. We got no trade reviews for the book, except for Publishers Weekly came in like right at the last minute with a starred review.
They gave you, I was going to say it was starred,
yeah,
which
they
is
starred
awesome.
review, which is like the A++ review, but nothing else. No Kirkus, no Library Journal, and almost all of their books get reviewed by these because it's a great publisher. And my only thought is it must be the quote unquote political stuff, like the abortion, gender affirming care. I don't know if they're trying to avoid political books or like that. They're like, again, like, is there a presumption this is just a lady book? I don't know. So it was very difficult, like just kind of seeing that we were struggling so hard to get, you know, some sort of like industry acknowledgement that the book existed, that it was hard to get press for it initially. Now, you know, that people have seen it and they're talking about it, it's been very exciting. People have been now reaching out to talk about it. But the week of the book coming out, it was crickets. Like, we had nothing.
Wow.
And it was very frustrating because obviously I feel strongly about these issues and like it like affects every woman, everyone assigned female at birth. Like, how is it that we're not getting the book out there? And that was very difficult. Anyone who has dealt with these issues and been frustrated by struggles to get someone to take it seriously, I felt the weight of all of their difficulties. And I was like, why isn't someone listening? This is crazy. It's so frustrating. But I think now, you know, I'm starting to see like the independent booksellers like championing it. They're posting and tagging on social media like this, you know, we can't recommend this book enough. Everyone should read this book. I see it, you know, we had a feature in Bustle in the Times in the UK. And it is really very moving. It's even more moving now because I think seeing that people are responding well to the book and realizing the importance of these issues has been very meaningful. So that was like definitely very difficult for me. I was like, you felt like it was your child that you had put so much care into and then like everyone thought your child was terrible. You know, so, but now I'm like, oh, people think the child is great. And so
Okay, good.
But yeah, no, that was the biggest challenge.
Cool. That's Karen Tang, author of It's Not Hysteria, everything you need to know about reproductive health, but we're never told. She's a board-certified gynecologist and a minimally invasive gynecologic surgeon. And she's also on TikTok, YouTube. You can see her on Instagram as well. Karen Tang MD is the handle there. Karen, thanks for taking time to talk to us about the book. It really is terrific. I hope it continues to spread. You're calling for a revolution here. You're calling for systemic change and better individual understanding. And I just, I'm here with you. I want to see it spread far and wide. So thanks for taking time to talk to us.
Oh my God. Thank you so much. This has truly been one of the best interviews I've ever done. I appreciate the amount of time and thought that you put into this. It's absolutely true. So thank you so much.
Thank you. Thanks for listening to Relationscapes. And hey, why not send this episode to your husband or to your partner? You know, the person who never seemed to care much about your PCOS, but needs to kind of like get their act together, learn more about it. Text this episode to them and say, hey, would you mind giving this a listen? I want to talk about it. Thanks to Camille Messick, who edited the transcript for this episode. You can find transcripts of every episode at relationscapes.org. There's a lot more to come on the show. If you're enjoying it, please go to Apple Podcasts and leave a review. I read them all. I cherish all the reviews. Mates of State provided our theme song. Relationscapes is part of the Dialogue Podcast Network. I'm Blair Hodges, and I'll see you next time.